Hi everyone, my name is Sita Smith, and as Rick said, I'm the Health Information Coordinator with the Department of Public Health, and I'm based at the Bureau of Infectious Disease. And because of that, I seem to have become responsible for 3 of the 5 public health objectives for meaningful use. I don't know what I did to deserve that, but that's where I stand. The good news for you today is that these 3 objectives are probably not relevant to any of you. I do think it's necessary for you to know about them and to be able to say to people, no, we can't attest to those because there's a lot of confusion out there. So I will run you very quickly through the objectives. So these are the 3: electronic lab reporting, syndromic surveillance, and the specialized registry. And it's the last one that seems to create a certain amount of confusion. So around, if I don't answer your questions here, I'd be happy to talk to you afterwards. I see some nods over there. Syndromic surveillance is the most straightforward one. We only accept data from hospital emergency departments, okay? So if the state says that's the only source from which we accept data, then that excludes everybody else. We're using the CDC-sponsored National Syndromic Surveillance platform, and just to keep you informed, we've got 29 out of about 70 eligible hospitals on board, and that captures about 55% of all emergency department visits. Nice for you to know because that data source is going to be there for people in the long term, but not relevant in terms of your meaningful use attestation. The same actually applies to electronic lab reporting. There have been regulations in place for a very long time in Massachusetts that require hospital laboratories to report infectious diseases to us electronically. Pretty much all the hospitals in Massachusetts do this already, every day. We have a bunch of commercial labs like Mayo and Arup and LabCorp sending us electronic lab reports. There's only 2 hospitals which happen to be the same one that were mentioned earlier on, but they're tiny, and it's a big effort for them, and we're working with them to onboard them. 5.5 million is the scale, that's the number of pieces of information that came into our infectious diseases database in the year 2014. So that's the scale of the ELR. But again, we're really, for meaningful use purposes, we're only collecting from eligible hospitals. We do collect from, for example, sexual health clinics that do on-site testing. And if you're one of those and you do a lot of testing on-site, reach out to us. But you're not going to get meaningful use points on that. So, Specialized Registry, that's just the ONC, it's paraphrased from the ONC description of what a specialized registry is. What we have done at the Bureau of Infectious Disease is we've declared that our surveillance database is a specialized registry. They said to the states, well, as long as you declare that something is a specialized registry, then say it is. So we said, okay. And the reason we did that was because we do accept case report data, so from electronic health reports, and we accept them from selected eligible providers. Okay, I'll explain what I mean in a minute. But basically, what we do is we use selected algorithms to dive into EHR systems, and then along with the lab results, they will pick up extra information, enhanced information that we need. So it's much more than an electronic lab report. Couple of things you should know. We're only looking at STDs, that's chlamydia, gonorrhea, syphilis. We're looking at acute hepatitis, not chronic, and we're looking at active TB. That's all we're collecting at the moment. We're working with the Mass League of Health Centers to develop algorithms for collecting HIV reports. And the reason we have this algorithm is that's what goes into an EHR and says, pick this case or that case. and not, pick case A and case B, but not case C. It's complicated. It's the format in which these messages are sent through is HL7, and it's a lot of work to apply the algorithms and to validate it. So what we're doing at the moment is we're only working with very large groups. So when people approach me to say, can we report to your specialized registry, I will say, if the total of relevant cases in a 12-month period is more than 1,000, please come to me, and we'll talk about onboarding. If it's less, then at the moment I'm writing exclusion letters, which I really don't want to be doing because that's a lot of exclusion letters. But I've written effectively what's in the exclusion letter, what's in here. It's being approved, and that's going to go on our webpage. So for attestation, what you need to submit is a snapshot of that webpage. But if the webpage doesn't have it, by the time you're attesting, then my contact details are on here, and I will send you a letter saying, yeah. But the issue is when you write to me, I have to say, have that correspondence with you. I have to say, well, what's your incidence? And you say, oh, we don't see any of these cases. And then I say, on the basis of low numbers, you get an exclusion. Whereas if you wait till the web page is up, then you can just say to the auditors, well, we only have 20 of these cases, and this is what the state is saying. This might change, okay, as we move along, and we get better at it, and we get more resources. It might come down to 500 cases or 300 cases, but according to ONC rules, we have to give people a 6-month warning. So once we put it on the website, then we won't even be looking for 6 months after that. Just by way of information, what we're collecting in these enhanced reports is diagnostic codes like ICD-9 and ICD-10 codes. We're collecting treatment information, and we're collecting pregnancy status. And for us, all those are very important from the perspective of case management, especially for SUDs, because if you know someone's pregnant, then you know to triage them in the queue. If you know what medication people are getting, then you get a much better perspective on what is a population perspective on what's being prescribed. So that's what we're looking for at the moment. So if anyone's got more than 1,000 of those particular cases, STDs, acute hepatitis, and active TB, please do come and see me. We're very interested in talking to you. I just put a web page that has a summary, which I think most people have seen, up there for reference. And yes, please do come and ask me any questions you have afterwards.
Good morning, everyone. So my name is Tricia Charles, and I work for the MIIS. Out of the group here, does anyone know if they are already reporting data to the Immunization Registry? Oh, yay, wow. Okay, great. So you guys are in a really good spot, and I'm sort of here today to go over some of the changes that were instilled with the new final rules. So I'm going to kind of cover some of those at a high level, but definitely call our help desk if you have further questions or come up and talk to me afterwards. In this first slide here, I'm just going to talk through this a little bit. As you can see from the beginning in 2011, our registry through the state is a little new. So in 2011, we started receiving electronic data exchange messages into the registry. We started with a total of 9 sites, so that was feels like forever ago. And as you can see, every year we sort of increase those numbers a lot, but in 2013 is really when we vamped up those numbers, and that was in the beginning stages of stage 2, which a lot of people needed to get on for meaningful use. So we thank meaningful use in that respect. And as you can see, from 2013 to 2014, we almost doubled our numbers, and then as of this year, we have over 1,000 sites reporting data. And that number, right now it says 1,022, but we're actually more closer to 1,100 sites right now as of November. So we encourage you to use the system. We know this for meaningful use, it's a lot of sending data to meet the measure, but just wanted to remind people that the registry is there to be utilized and to help with patient care. Okay. So one of the biggest changes, I think, was that we had stage 1, stage 2, and stage 3 for meaningful use. Stage 1 was really just sending a test message to the registry and making sure that your EHR was able to do that. Now they've decided that in order to make it easier for you guys to sort of consolidate everything under the same set of requirements. So there's still stage 1, stage 2, and stage 3, but you can follow the same requirements for all of these stages to report data to the registry. And to do that, they've now renamed the ongoing submissions term to active engagement. So there was also, I think, some confusion around what ongoing submissions really was. So they changed it to active engagement, which simply means that you're actively trying to connect to the registry, or you've reached out to us and we are working with you in some respect. So the options here, option 1, and I don't really love the terminology option 1, option 2, option 3, only because it sounds like you have a choice and you really need to kind of go in order. So for option 1, you can meet the active engagement by submitting to us your registration of intent. And this is the big one that a lot of sites miss. So if you are the person that is supposed to be doing this, I encourage you to go to our resource center and make sure that the registration of intent has been completed, and it's been completed within the right time frame. So that's sort of the key piece here. You have to register your intent within 60 days of the first day of your EHR reporting period. So for a lot of you, you may have registered your intent earlier this year, so you might want to just make sure that you did it within that 60-day time window, which would have been January and February. If you did it after that, you have the opportunity right now to change your reporting period to make it fit into that window. So if you have questions about that, I can definitely talk about that more after the talk. So once you've registered your intent with us, just sort of waiting for an invite from us will help you meet the measure for meaningful use. So as long as you've done the intent, there's a form you have to complete, and then you've done it within that 60-day window, then you would just hang out and wait for us to send you an email or contact you and say, we're ready to work with you and onboard, okay? And then that is option 1 for active engagement. The second option is to actually begin working with us. So we'd start working with your EHR vendor, and we'd be testing and validating the messages that are coming over to our testing environment. And as long as you're doing that, and you're being responsive to us when we ask for corrections, or your vendor is being responsive and fixing the issues that we have found, you'll meet the measure that way. So that's option 2 for active engagement. And then finally, option 3, that's when you've completed all your testing and validating, and you're submitting data to the registry in an ongoing submission. So that would be option 3 for active engagement. Now, if you're already submitting data to us, so I know a lot of you are, you would need to register your intent if you have not submitted ongoing submissions in your last EHR reporting year. So if your EHR reporting year last year was the 90-day period, say in January was the first quarter, if you didn't start submitting ongoing submissions until October or November, then I encourage you to register your intent again for this. If you didn't register intent last year, I would encourage you to register it for this year, just because according to the way the words are in the final rules, you have to have been submitting ongoing submissions in your last year's reporting period. So just sort of to cross all your T's and dot your I's. It's just a good thing to do.
Can you repeat that again, please?
Sure. So if you're submitting ongoing submissions to the registry and you didn't register intent last year, but you're submitting ongoing submissions, but it wasn't until after your EHR reporting period last year that you started the ongoing submissions, I would encourage you to register intent this year, just to be safe. The wording in the final rule states that you can meet the measure as if you're submitting ongoing submissions since your last year's EHR reporting period. So just some wording on that. So prior actions count though. So if you are someone who registered intent, I'll take your question.
Oh no, I didn't have a question.
Sorry. If you registered your intent earlier this year for the full year EHR reporting period, as long as everyone's on the same page, we have now changed it to a 90-day reporting period. The final rule states that if you registered intent for the full year, you do not need to go back and change your registration of intent. So you can leave it as is. And also, if you registered intent last year or the year before, you don't need to do it every year. So one intent will cover ongoing. So just keep that in mind. And if you have already done the stage 1 requirements earlier in the year, so you already sent a test message to do the original stage 1, you don't have to then go in and register your intent for stage 1. The test message will still count towards meeting the measure. So where to get started? So you definitely want to register your intent if you haven't already, and again, I encourage you to double check that your registration of intent is within a 60-day window of your EHR reporting period. If you did register your intent with us and it is outside of that, you can easily edit your intent with us through our Contact MIS Resource Center. You also want to make sure you review the MIS legislation and then also our clinical and technical requirements. And those are also all available on the MIS Resource Center, and the web address is right there. And this is just a screenshot of the home page of the Resource Center. And if you look to the right here, you can see that you have a login area. So I know a lot of you go through this website sort of once and you register and then you forget about the fact that you can log back in, and then you can go to the Meaningful Use tab at the top, and that's where you'll find your registration of intent and your report card. We do have a report card that you can print out and submit that to MeHI for when you attest. Also, just as a reminder, you still have to follow the applicable state laws for reporting to us, and there is a legislation that you have to report immunization data to the MIS. So looking outside of meaningful use, you still need to report to us, and we will onboard you as you come to us. I would say that you want to make sure that you have looked over our technical requirements to make sure that your EHR can submit all the necessary data fields, and you can have them look at those requirements to make sure that they can add those pieces in if they're missing. So the message that you would be sending over is through the HL7 2.5.1, and I think most EHRs are doing this now, so you should be all set with that. And the clinical integration piece, this is more around the legislation rather than meaningful use, but this is a requirement for us, so we won't allow you to submit ongoing submissions to our registry unless you've also completed the clinical requirements that are set forth by the legislation. So those work around patient notifying that the data is coming over, and also the patient's right to limit who can see that data once it's in the registry. And once the technical and clinical pieces are in place, then you would conduct some data quality checks before we actually open up those patient records into the registry. And then you would go live and be ongoing submissions. So that is all I have right now.
So I'm Susan Gershman, and I direct the Massachusetts Cancer Registry at the Massachusetts Department of Public Health. So to start off, I'm not sure how much all of you know about cancer surveillance. I thought I'd give you a background of the Cancer Registry. So it was established in 1980, and it's by state law, Massachusetts General Law, Chapter 111, Section 111B. And it took about 2 years to develop the database. I wasn't there at the time, and we had not as many fields as we have now. Maybe we had 50, we have like 250 now. In 1982, we began hospital case reporting. In 1992, and this was for invasive cases, they added in situ cases. Things changed in 1994. Back in the 80s, there were about 4 or 5 employees. We were only state funded, but federal funding under CDC, and this was actually federal funding that it was Public Law 102515, and it was sponsored by Bernie Sanders. So there was already a federal program under NCI, but covering about 26% of cases, say in the United States, but limited to certain states like Connecticut. I'm trying to think of the other states. Connecticut, I think it was Hawaii at the time, New Jersey, and certain regions, Detroit, Atlanta, and Seattle, Puget Sound. So once again, you couldn't get really national statistics. So the federal funding through CDC added to that, and it now covers, I guess, close to 100% of the population. CDC funds about 45 registries, and some registries are joint funded. They're lucky. 3 big states, New Jersey, not so big Kentucky, bigger in area than Massachusetts, but not population, and I believe Louisiana and California. So now there's 100% coverage. In 1995, we added treatment. In 1997, we started linking to death files, so identifying cases that somehow fall through the cracks and only identified through the death files. And we do have to follow back on some of the cases to see if we can find out were they diagnosed in nursing homes, hospitals that somehow missed them, etc. And that's part of our quality control work that we need to do. In 1998, we added outpatient reporting, non-hospital reporting. In 2004, we began collecting by law. We had to actually amend our law, benign borderline brain CNS tumors, and in 2014, MU2. So I always think that cancer surveillance is the emperor of surveillance systems. And one of the reasons for that is the power of the multiple organizations that work on cancer surveillance. So CDC, NCI, the Surveillance Epidemiology and Results Program, and that's the program that I mentioned that goes back to 1973. I believe it was part of Nixon's War on Cancer. The Commission on Cancer of the American College of Surgeons, so they run an approvals program for hospitals that have cancer programs. And in Massachusetts, we have 65 hospitals that report to us, and 43 of them are part of the COC's approvals program, and that's about 80% of our data. The North American Association of Central Cancer Registries, so that's an umbrella organization that focuses on certifying registries, education and training, research, and standards. And then the American Cancer Society. So we have a national format for MU reporting, and we're now in, we call it volume 2 actually, but it's NACER Data Standards and Data Dictionary, version 15.0, and in 2016 we moved to 16.0. And we have certification, and I'll say a little bit more about that shortly. And CDC actually does evaluate our data every 5 years, and Massachusetts has done really, really well. We're very proud of that. So annual admissions, 62,000. We have to take the admissions and consolidate them, because when we report for our national calls for data, and that's actually going to occur in the next week, we'll be reporting 2013, and in January or the end of January 2016, we'll report 2014. So we end up with about 42,000 consolidated cases. We do retain all admissions, and the database now has over 1 million cases. So this is our gold certification, and it dates back to 1997, so 16 years. And we also have, I don't know what you call them, they look like little emblems. We're trying to have them put on our web pages, so anyone interested in doing research will know that we have a high quality registry, but it's Registry for Surveillance and Registry of Distinction. We have one more little emblem that we're aiming for, and hopefully that will happen in 2016, and that's to have 90% of our 2014 data. So our data processors are working very hard this week doing all our final edits. So now, I do need my glasses. Meaningful use in cancer reporting. So I would say, I think it was 2013 we started working on meaningful use. And in 2014, I used meaningful use as a success story, and I called it Rockin' Down the Highway, MCR and MU. Unfortunately, we're not rocking. It's a very slow waltz, but it is set up so for those that do have cancer cases in their practices, we can receive that data, although not that easy. So you can see from the diagram that they're eligible providers, and then you have to onboard the highway. It has to be an HL7 CDA. We do acknowledgements. It's sent through webmail, and we use 2 CDC products, a Validation Plus and eMark Plus. And so eMark Plus will take this CDA message and convert it to our NACER format. We did receive one case, and it took CDC and the University of Kentucky to try to interpret it, and it wasn't cancer, so we were very disappointed. But we think we're pretty close now. So hospitals have been reporting for over 30 years. They report to us electronically through secure email. But CDC wants us to have at least 90% of physician to cancer registry reporting. And so that's one of the reasons we became part of MU Stage 2, and we were not part of Stage 1. So originally, for Stage 2, I guess that still exists, right? You have 3 of 6 menu objectives. You can report, you just heard syndromic surveillance, progress notes, imaging results, cancer cases, and specialized registry. And I believe for meaningful use 3, cancer cases will be moved into specialized registry. And mainly, our focus has been dermatologists, because for non-hospital reporting, we get stacks of paper like this, 6,000 records, that we have to then put in our format. So it's very labor intensive. Just sorting it is unbelievable. So you have to sort it by year. We like to do it by site. And once again, melanoma from dermatologists. That's mainly what we've been receiving, and it's really important because it's documented. Most registries probably underreport melanoma. So I'm not going to actually read all these slides, but they're a great reference, and I know they're available on the website. But the final rule was published in the Federal Register October 16, 2015, and it's entitled Medicare and Medicaid Programs, Electronic Health Record, set of programs stage 3 and modifications to meaningful use, 2015 through 17. So this provides the documentation regarding attestations for 2015 to 2017. It sets up the stage 3 rules. So the bar is now raising, and for us, things have changed. This past October, we've had, I think, 25 requests to register with us. Other months, maybe just a couple. So I think it's going to be very exciting and a win-win for providers as well as for the cancer registry. We don't want paper anymore. If we can get data from you electronically, we will link it against our file, add it as an admission, and consolidate and take the best information you've provided and add to or substitute for what's not great in our record. And this is another website that you can go to with quotes, which I won't read, so you can go ahead and read them on your own. And there are alternate exclusions for 2015 for cancer reporting. If in stage 1, you may now choose cancer reporting, but you don't have to. It was not originally, as I mentioned previously, part of stage 1. If in stage 2, you are planning to attest for 2015 without reporting cancer, you don't have to suddenly report. You're still able to attest by using alternative exclusions. And there are different time periods. I believe you can register with us up until December 1st, and that would be for 2015. And for 2016, I believe it's March 1st. But once again, you can check on that. And for cancer surveillance anyway, you have to have certified electronic health record. If you don't, I guess you can kind of pressure your vendor. And we think with including cancer surveillance as part of specialized registries, it may be an incentive for vendors to add cancer surveillance as part of meaningful use. So I think it's important to know that it's not just for dermatologists anymore. Any provider who diagnoses or treats cancer will be more likely to choose cancer registry reporting, and we are ready. So how do you report to us? You have to register by the 60th day of the reporting period, and you can see, you can contact me, it's really bold, and I'll send it to Mary. So we'll send you a registration form and fill it out, you send it back to us, and we'll send you an acknowledgement. You just have to register once. It should cover any future reporting. And it's not a commitment to report, but it's in place if you decide to. You have to make sure that you have, once again, the certified health record technology. And there are some qualifications. You can register without it, then if you get it, you can choose 2 30-day chances to send test data after we invite you. And if you don't have the cert, you're unlikely to report you won't be able to. So you have to onboard the highway. We'll give you all that information. We'll give you the contact. Even if you're already on the highway, you still need to let them know that you want to report to the cancer surveillance because they have to update your account. Then there's the testing, validation period. We invite you, you have 30 days, and we have 30 days, and you have another 30 days, and then another 30 days, and hopefully we'll be able to get data, it will be ongoing, and once again, it's a win-win for everyone. So there are certain, like a goal for the end of the reporting period, be in production, be testing, responding to validation feedback, or you might be awaiting our invitation to begin testing. And you need to remember that it's really CMS. They determine if you've reached active engagement, grants exclusions, decides what measures and objectives you've met or failed. The state doesn't determine any of this. This is our website. our data are in all the national websites, CDC, NCI, the North American Association of Central Cancer Registries, their cancer profiles, and we have state and county level data available. Also, we're just about to have on our web pages 40 reports with preliminary data for 2013, trends data. We're really excited about that, and lots of research is done with our database, with our data. And I think one of the most exciting is a linkage with the All Payers Claim database. So that's part of a Harvard project. And CDC, they're the experts, for us anyway. They did look over all our slides because we were really concerned about making sure that the information we presented was accurate, and MU being somewhat new to cancer surveillance, they have a unit for cancer surveillance that has gone through the 1,000 pages, etc. So it's meaningful use at cdc.gov, and we acknowledge the Centers for Disease Control and Prevention for their support of cancer surveillance, and it's 80% of funding is from CDC.